Recording. Okay, perfect.
Guys, I'm on Zoom. Close doors. Thanks.
Okay, Liz, I think we should start. Should we start, everybody? Yes? Yes, okay. I just wanted to welcome everyone. I wanted to also say, hope everyone is doing well today. I wanted to thank you all for taking the time to join us to hear from our leading medical experts and researchers on hereditary cancers and population-based testing for cancer susceptibility genes. Today's webinar is brought to you in partnership by Yodeah, the Prevent Hereditary Cancer Coalition, and 1 in 40. My name is Allison O'Hara. I am the executive director for 1 in 40. We are a nonprofit organization that raises awareness of the 1 in 40 risk to Ashkenazi Jews of inheriting a BRCA gene mutation and provides the support individuals and families need to effectively manage their cancer risk. As I mentioned, this program is brought to you in partnership with also Yodeah. Yodeah is a nonprofit organization dedicated to educating the Ashkenazi Jewish community on their increased risk of carrying a hereditary cancer gene and facilitating cost-effective genetic testing. In addition, also the Prevent Hereditary Cancer Coalition, which Yodeah is a founding member of, and Liz is the founder of Yodeah, Dr. Kramer, I should say. That was established in 2018. And it's a diverse group of organizations and thought leaders from around the world, really committed to healthcare policy and reform that leads to the prevention of cancers caused by inherited gene mutations. I also just wanted to quickly thank our sponsors, the Allergan Foundation, Pfizer, New England Development, AstraZeneca, Clovis Oncology, GlaxoSmithKline, and Goldstein and Billido. Now I would like to just quickly introduce our moderator for today, Dr. Elizabeth Ecken-Kramer. She is a board certified gynecologist, assistant professor of obstetrics and gynecology from FIU, Herbert Wertheim School of Medicine in Miami. She's also part of the presidential task force for the ACOG and the founder of Yodeah. Dr. Kramer will also be introducing our wonderful panelists today, which includes Dr. Sophia George, Dr. Ranjit Manchanda, and Dr. Efrat Levy-Lahad. So please join me in welcoming Dr. Kramer. Dr. Kramer? I'll stop sharing my screen too, so you can share yours.
Thanks. Actually, I'm actually not going to share.
Okay.
But thanks, Allison.
You're
And let me start by saying how thrilled I am to be here right now. As Allison said, we started Yodeah a handful of years ago, like 1 in 40, we talked about BRCA. BRCA is one of the most well-studied cancer susceptibility genes, having been identified many years ago. And what I found really interesting, and what led me to establishing Yodeah, is although the increased prevalence in Ashkenazi Jews has been known for many years, it was only last year, through the wonderful research from our panelists here, that we were able to change the needle and push the needle such that all Ashkenazi Jews, regardless of family history, are recommended to be tested, both men and women, if they have one of 4 Ashkenazi Jewish grandparents, which is huge. Today's conversation is about this, where we started with BRCA genetic testing and where we're going with BRCA and cancer susceptibility genes as part of multi-gene testing. Our goal is prevention, because by identifying our patients who carry these genetic mutations, we can decrease cancer burden, either through increased surveillance, chemoprevention, or surgical methods. And I'm really thrilled to be having this conversation with Dr. Levy-Lahad, Dr. Manchanda, and Dr. George. These are the researchers, and again, I apologize for being so effusive, but they really contributed to the growing body of literature on hereditary cancer and prevention. And it is through their research, I believe, that led to the move by NCCN in favor of population-based testing for BRCA and Ashkenazi Jews. And I'm going to introduce them very briefly, and I apologize ahead of time because we could spend an hour on the publications and their wonderful, wonderful contributions to this conversation. But we have Dr. Fat Levi Lahad joining us from Israel. Dr. Levi Lahad is the director of Medical Genetics Institute at Shaher Zedek Medical Center and associate professor of internal medicine and medical genetics at the Hebrew University Hadassah Medical School. She has published multiple articles about population-based testing of BRCA in the Ashkenazi Jewish population, but she also has research that involves genetics of breast cancer in other ethnicities, as well as genetics of rare diseases. We have Dr. Ranjit Manchanda joining us from the UK. Dr. Manchanda is a gynecological oncologist by training with PhD at Bart's Cancer Institute and a co-lead for the prevention theme of the CRUK Bart Center. He is part of multiple scientific groups focused on prevention and early detection for ovarian cancer. And last but not least, from our neck of the woods, we have Sophia George, who's an associate professor in the Division of Obstetrics and Gynecology at Leonard Miller University of Miami School of Medicine. Dr. George is a molecular geneticist, PhD, and her interest is sporadic and hereditary breast and ovarian cancer, as well as endometrial cancer. She is the co-leader of the Women's Cancer Working Group of the African Caribbean Cancer Coalition and a co-PI in the Transatlantic GYN Cancer Research Consortium. I really boiled it down to very basics because their research and their brain power speaks for themselves. So, but I'd like to start the conversation with where we started with BRCA testing. Dr. Levi Lahad, will you talk to us about that? Perfect. And I think you have to unmute. Or unless we have to unmute her. Perfect.
Okay, did
Thank
it?
you.
So thank you for the kind introduction. And I'm thrilled to be part of this webinar, and thank you for inviting me. I've been tasked with the next few minutes explaining how did we even get to the thought about population screening for BRCA1 and BRCA2. Just one second. So as I'm sure all of you know, the BRCA1 and BRCA2 genes were identified about 25 years ago as a result of research into families with many cases of breast and ovarian cancer. And I just want to briefly remind you of the inheritance of these mutations in these genes, which is autosomal dominant. As you can see here in this pedigree, I actually showed the man as having the mutation because it's very important to remember that paternal inheritance is just as possible or likely as maternal inheritance. And the other thing you can see here is obviously that if one parent has a mutation on one of their copies of the BRCA1 or BRCA2 gene, the risk to their offspring and to other first-degree relatives is 50%. So very shortly after these genes were identified, it became clear that Ashkenazi Jews have a particularly high rate of specific mutations in these genes. This is not a rare situation in Ashkenazi Jews. It's a fairly homogeneous group, genetically speaking. And these three mutations, 2 in BRCA1 and 1 in BRCA2, altogether have a frequency of 1 in 40 in Ashkenazi Jews, which is the reason for the name of the organization, 1 in 40, but is a very important number to remember. The other important fact here is that not only are these mutations particularly common, but other mutations in BRCA1 and BRCA2 are actually quite rare. And in a larger study done by Mary Claire King's group, they found that among 1,000 breast cancer cases, of those who had mutations, 94% of them were these common mutations. So it's rare to find a different mutation, and it's very easy and very cheap to test for these specific mutations. So as a result of this, in the early days, we were able to do very large studies in Ashkenazi Jews that were not possible in other populations because sequencing was then very expensive. Now that sequencing is much cheaper, this of course changes the story, but we're still on the Ashkenazi Jews and the specific founder common mutations. Another important fact that emerged in the following years was that these mutations account for a whopping 40% of all ovarian cancer cases in Ashkenazi Jews. Generally, when we speak about inherited cancer, we say that about 10% of cases are caused by inherited mutations. For ovarian cancer in Ashkenazi Jews, this number is much higher and is 40%. For breast cancer cases, it's actually pretty similar to what we would generally expect. So about 11% of all breast cancer cases in Ashkenazi Jews are explained by these mutations. So why would we even bother to identify BRCA1 and BRCA2 carriers? So today, in fact, I would say most certainly oncologists would say that the reason we want to identify them is because it has implications for treatment, very much for ovarian cancer, but now also for breast cancer. I'm sure you're all aware of PARP inhibitors, the platinum sensitivity of cancers that originate in BRCA1 and BRCA2 carriers. But as a geneticist, not an oncologist, what I'm really interested in is using this information for prevention, for preventing breast and ovarian cancer. So obviously prevention is in unaffected women, but I want to make the point that when we identify mutations, we also can offer prevention for the next cancer in breast cancer patients, specifically another subsequent breast cancer or a later ovarian cancer. And the other important part is relatives. Once we find a carrier, we know that her relatives are also at risk, or what we call cascade testing. So I'm going to just give a brief example of what this means. So this is a 49-year-old woman who was diagnosed with ovarian cancer. And today, and certainly even in the past, all ovarian cancer patients, and especially Ashkenazi Jewish ones, were tested for the common mutations. So this is a woman who was diagnosed with ovarian cancer at age 49. She has no family history. And we test her and we found out that she is a carrier of the 5382 insert C mutation in BRCA1. So this is a very frustrating situation to identify a woman after she's affected, because it means we've missed the opportunity to prevent her cancer. And obviously, if we want to prevent cancer, we need to be testing unaffected women. But the issue is that even to this day, and even with the latest NCCN guidelines, most commonly unaffected women are only tested if they have a significant family history. The problem is that we have shown in many other studies that about 50% of carriers do not have a suggestive family history. And if you're basing your testing criteria on family history, you're going to miss these women. And if we look at this example, this woman inherited the mutation from her father. It seems that there might be a lot of women in the family who are at risk and were not affected with cancer. But in fact, what happened in this case is that this woman's 93-year-old mother was still alive, and we could test her. And that proved that, in fact, the mutation was inherited from her father. And you can see that this is a family with many males who did not have many offspring. So it's not that that the mutation does not cause high risk. All these women who did not get cancer simply were not carriers, and the mutation came from the other side of the family. So as a result of this, and my frustration from seeing these young women with cancer who we could have prevented, the question was whether, in fact, if we have carriers that don't have a family history, are they still at risk for breast and ovarian cancer? So we decided to look at cancer risks in carriers ascertained at the population level. And the way we did that was we tested over 8,000 unaffected Ashkenazi Jewish men who were not selected based on their family history. And we identified among them 175 carriers, which is about the expected rates. So their families are, in fact, population-based BRCA1 and BRCA2 families. And in these families, we tested all female relatives. There were more than 470. A little over half of them were carriers, and we could estimate cancer risk in these carriers. And these results were published in this paper in 2014. And what we found, this is the bottom line, is that the combined risk for breast or ovarian cancer in these women who were ascertained totally through unaffected men was very high. And in BRCA1 carriers, it was 83%. And in BRCA2 carriers, it was 76%. So where were we in 2014? So we know there's a 1 in 40 prevalence of the common mutations in the Ashkenazi Jewish population, which in Israel is 40% of our entire population. We know that carriers account for about 10% of breast cancer cases and 40% of ovarian cancer cases in Ashkenazi Jews. And we know that there are effective means of surveillance. I'm going to touch a little bit more on that later, but there's very effective surveillance for breast cancer, and there is very good prevention for both breast and ovarian cancer. What we showed in our 2014 study was that carriers at the population level are at very high risk of developing breast and ovarian cancer. They're not protected, even if they don't have family history. And indeed, 50% or more of carriers would not be identified based on family history. So we asked ourselves, what should we be doing? And we thought the answer was pretty obvious, and that is to screen all Ashkenazi Jews for BRCA1 and BRCA2 mutations. So how would we go about doing that? I think you can have a great idea, you can have great science, but ultimately, the proof of the pudding is in the eating, and you need to find a way of implementing the insights you get from research, and that's often a complicated process. As I know is true in the United States and is certainly true in Israel, waiting times for genetic counseling are extremely long. And in fact, it is not at all clear that most women need in-person genetic counseling before they get tested. In fact, many of them would probably just get tested and then deal with the information at post-testing. And we've actually done a series of studies. The references are shown at the bottom of the slide here, showing that BRCA1 and BRCA2 testing is certainly possible without in-person genetic counseling before testing, just with prior written information and having a telephone hotline. And that in terms of knowledge, psychosocial measures, and familial communication, this type of large-scale screening that does not require pre-test genetic counseling is certainly possible. So what's the situation now in Israel? We petitioned again and again and again, 3 times. Israel has a national health system, and every year there's a public committee that decides which new drugs and new technologies are going to be part of what every Israeli citizen receives. And in January 2020, population screening for BRCA in women with any Ashkenazi ancestry was approved for inclusion in the list of services. The service, all medical services in Israel are provided through 4 HMOs. And 2 of the HMOs, Clalit, which ensures 50% of the population, and Maccabi, which ensures 25% of the population, are just now, this is now November, this was approved in January, they're just now beginning to implement it. Obviously, the reason for this, I would say, snail pace is they were, to their credit, I have to say, they were busy with Corona from about January, and they still are. But it is beginning to be implemented, so stay tuned as to how it actually rolls out. I just want to mention how important this is. Just about the same time that the Israel Public Committee approved BRCA testing for all Ashkenazi Jews, Elizabeth Wurtzel, a 52-year-old author, died of metastatic breast cancer at age 52. And you can find online the piece she wrote in 2015 when she was just diagnosed, which is called The Breast Cancer Gene in Me. And I'm just going to quote her here. She says, "Jewish organizations have done too little about BRCA. Hadassah has supported research on BRCA, but so much for that." In April, this was in 2015, I will say. In April, its president, Marcy Naton, released a statement titled, "Testing is not for everyone." The test sounds simple enough, she said, but understanding what you could do with the results can be a complicated, gut-wrenching journey. And Elizabeth Wurtzel wrote, "Yes, it can, but not nearly so much as cancer." And I think that's really the message. We have it in our hands. It's a simple test, very inexpensive. And I think really it's more a question of awareness now than anything else, because I think the evidence is clear. So thank you for listening, and I'm waiting to hear the next exciting parts of this symposium.
Thank you. That's amazing, and it speaks directly as to what the Prevent Hereditary Cancer Coalition, Yodeah, and 1 in 40 truly are all about, and it resonates in my brain and my heart. Dr. Ranjit Manchanda, will you talk to us a little bit about your research as well on hereditary cancer genes?
Thanks, Liz. Yes, I'll just share my screen. It's a great privilege and honor to share the platform and the webinar today, and thank you for having me here. I think, Efrat, you need to stop sharing me. Yeah. Okay, I'm sure, is that visible?
Mm-hmm.
Yeah, okay. Thank you. Thank you. I'm tasked with talking a bit about our UK experience, so it's going to be just a bit of a whistle-stop set of slides over a few minutes, just with the highlights. Just to acknowledge our funders who supported this work, the Eve Appeal, Cancer Research UK, and the NHS Innovation Accelerator, and also to acknowledge the huge number of Jewish charities, organizations, and other support groups we worked with in the UK. So as Efrat pointed out, this strategy is fairly simple. If you test everyone, you pick up more people at risk, and therefore you can do more early diagnosis and prevention, and you can prevent more disease and prevent more cancers. And that's really what we all want to do. And I think population testing affords us the opportunity to do that in a paradigm changing way, which will prevent many more cancers. So one of the things we discovered in the UK is we looked at all the lab data which had across a 16 million population in London and looked at how many people had BRCA testing and how many carriers were identified, we discovered that the majority remain unidentified. So we've had 25 years of BRCA being around, 25 years of testing, and 97% of general population and 90% of found a mutation Ashkenazi Jewish population who BRCA carriers remain unidentified. So clearly, I think the health system needs change. And when we modeled it, we saw that we'd have to wait for a very, 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 very long time to pick up people at risk. And as pointed out, you miss half the people anyway, even if the current system is working at 100% efficiency. So I think we need change. And as highlighted earlier, why do we need to wait for people to get cancer to identify people whom we can prevent cancer? And that is an opportunity lost, and we all agree with that. So if we were to test populations, then clearly we need to pick up more people at risk. We need to know that the risk of cancer is high, and Efrat's work nicely shows that. We need to understand the impact on quality of life, psychological well-being. Is it acceptable? Is it feasible? What are the new models of delivery? And is it cost effective? Can the health system afford it? And of course, then we need to bear in mind the principles of population screening. So in the UK, ours was a randomized trial. We had 1,034 men and women randomized to either population testing or family history-based testing. And we looked at these range of outcomes from the point of view of health economics, psychological consequences, quality of life, and carriers detected. We did this in a community model across 6 centers in London. And the slight difference in our study was that we did do pre-test counseling for everybody in a format which I'll explain. We did publish a few papers over the years, and I'll just summarize the results in the next 3 or 4 slides. So we found about 1 in 40 people carry a BRCA mutation in the Ashkenazi Jewish community. Our prevalence is about 2.9%, roughly evenly split between BRCA1 and BRCA2. If you look at people who had a family history of cancer, fulfilling cancer gene testing criteria, it's about 10%, 9 to 10%. But if you look at people who didn't fulfill the cancer gene testing criteria, then it's about 2%. So it's still relatively high, and that's the proportion you'd miss. We found that 60% of the BRCA carriers were missed through the clinical criteria-based testing prevalent at the time. In a nutshell, we showed that population testing was feasible, acceptable, had high satisfaction, was cost effective, could be undertaken in the community setting using non-inferior, cost-efficient pre-test counseling approaches, and did not harm psychological health or quality of life. So in a randomized manner, when you compared it to standard family history-based testing, there wasn't a difference. We did find that anxiety actually reduced with time and reduced more in the population testing arm than the family history testing arm. I think it's a statistical reduction rather than a clinically meaningful reduction, but the key thing is it's not going in the opposite direction. But we did find a reduction in anxiety. There was no difference in depression, uncertainty, overall impact of testing or quality of life as outcomes between the two approaches to gene testing, and distress and health anxiety reduced with time. When we asked people who came in, clearly all studies are self-selected populations. There was 96% interest upfront, but only 60% intention to undergo testing initially, and then we ended up with an 88% uptake. Reassurance and reducing uncertainty were the major factors that were pro-testing, and women who were married or cohabiting were 4 times more likely to take up testing than those who weren't. Various limitations and risks associated with testing, which are well reported in the literature, were factored into decision making, and they did discriminate between acceptors and decliners, which is what one would hope to see. This is stuff we have analyzed, we haven't published it yet. And that's, do people who get a negative result then start smoking more or drinking more or eating unhealthy or not going for the routine mammograms? Does it have a negative impact on lifestyle? It didn't. So we found that for some reason there's an increase in vitamin intake in population screening compared to family history screening in that arm. But there was no difference in alcohol frequency, quantity, physical activity, diet, fruit, vegetable, meat intake, smoking, or breast screening behavior between the two groups in that study. That was reassuring. We published a few cost effectiveness analysis, and in a nutshell, it's cost effective for the health system, both in the US and the UK. It's cost saving for up to 2 to 4 Ashkenazi Jewish grandparents and cost effective for 1 Ashkenazi Jewish grandparent. But there are very few interventions in medicine that save lives and money. This is one of them. From the point of view of implementation and using different approaches to deliver information, if I describe the model that was done in Israel, we randomized people to a DVD-based assisted counseling versus a group counseling versus individual one-to-one counseling, and we found that it was non-inferior. And we published on that. So you could do it in the community setting using a DVD, and it was more cost efficient and effective. We have recently done a general population pilot study, and we've used a similar sort of approach where we've not done formal pre-test counseling, but we've used a web-based decision aid, and we had an optional telephone helpline. So women can pick up the phone and call someone both for consenting or counseling for any questions. We're about a 13% uptake there. So 87% of women decided that they would go for gene testing without the need for a pre-test counseling support. And those who did go for pre-test counseling support actually were women who scored higher on the anxiety scale. So in a sense, that's a good thing, because if you are more anxious, then you have that helpline available and you do access it. So I think this is a model which is likely to be taken forward in the future. We've done cost effectiveness work also on population testing beyond the Jewish population, and we've shown that panel testing for breast and ovary cancer genes is cost effective. And without going into too much detail, you prevent tens of thousands more cancers depending on the population of the country compared to the current clinical model if we did a population-based approach. So there's huge potential impact if we just change the way we do things. We also show that it's applicable across many countries and different health systems. And we showed, again, you could prevent many more breast and ovarian cancers. And we looked at low income, middle income, and upper income countries, and UK, USA, Netherlands, China, Brazil. And the most sensitive factor is the cost of testing. So as the cost of testing falls, and we can see all of us see it falling over the last 5-10 years, this is going to become more globally applicable. Pulling it together, I think the principles of population testing are well described. We need to keep in mind, because we're talking about different genes, not just the BRCA genes, that there needs to be analytic validity, clinical validity. So you must be sure of the analytic assay you're using. You must be relatively sure of your penetrance. There needs to be a benefit of doing tests. Don't test just for the sake of testing. Some clinical utility. And we need to consider the ethical, legal, and social implications. And I think these are important principles to bear in mind as we develop a population testing strategy further beyond, within the Jewish, but also beyond the Jewish population. And I think you pull it together, then stakeholder engagement is a key thing to consider. So all stakeholders need to come in, and that involves the religious community, patient public engagement, the various parts of the community, charities, advocacy groups, insurance companies, the whole of society coming together. There's the issue of building resource and capacity we need to consider. And then we need to have what I call context-specific implementation models. So what works in one health system is not going to be the ideal model for another health system. So we need to have context-specific health models, but bear in mind the principles of doing them remain the same. So there's an entry point in access and how that comes in, how the providers come in, or your physician or your GP comes into the system, how you do your counseling, how you do your data management, consent, digital flow, how you return your result, how you do cascade testing, and how you loop it all in so that you have downstream testing. So bearing in mind, I think those principles, I think each country and each health system will have to develop their own strategy for delivering population testing in the future. Yeah. And so just some commentaries we publish, but that's sort of our experience on population testing in a nutshell.
I know it's a very high overview. Ranjit, thank you so much. I'm going to get back to you in a few minutes because I want to hear Sophia's talk about Latin and the Black population, but I do want to dive in a little bit more after about general population to decrease the risk of ovarian cancer. But so, Dr. George.
Hi, good afternoon, everybody. And again, thank you, Liz and Allison, for giving me the opportunity to talk to you today on the topic of Latin America and the Caribbean, and some of the work that we've done, but what is also known in the literature about this landscape. So I don't think I need to tell everyone about health disparities in the context of breast and ovarian cancer, but I just felt it was important to put that out there because it's a population that we don't usually think of in the context of genetic predisposition to breast and ovarian cancer. So one of our links to studying hereditary diseases in Black women is the fact that we know that half of the women who are diagnosed, Black women who are diagnosed with breast cancer, diagnosed at an advanced stage, but also Black women have a higher likelihood of developing triple negative breast cancer and dying. Another thing that we also know is that in the Hispanic population, breast cancer is a leading cause of death. And of course, there are multiple factors that contribute to that, but one of the factors that we think, and we have been studying and others, is the genetic aspect. So what is known about breast cancer in Latin America? I have here just data from WHO, IARC, that showed showing the incidence in blue. So you can see in the Caribbean in particular, you have some dark spots in Latin America also. And then you can look at the mortality, and again, you have some dark spots there. And so why are we studying from the perspective of being in Miami, women from Latin America and the Caribbean, is that a lot of the Black population, about 10% of the US Black population, are recent immigrants to America, and they come from predominantly Jamaica, Haiti, Nigeria, and of course, well, Nigeria is one of the populations, but the Caribbean Black population is a big contribution of new immigrants, Black immigrants, but also long-standing second, third generation Blacks, also of Caribbean descent. And we think about 18% of the US population currently has Caribbean ancestry. And of course, we also know that based on the landscape of the United States, that we have growing Hispanic population, so in the comprehensive way. So what do we know? What's in green, we just spoke about. We heard from Efrat and Ranjit. But what our group have studied and showed is that in the context of the Bahamas, where specifically Dr. Judy Curley made these observations almost 10 years ago, that Bahamian women were diagnosed at an advanced age, young, with triple negative breast cancer, and went ahead and got funding to do germline genetic testing in that population. So as a summary, it was followed up to identify whether these women who had the germline genetic mutation in BRCA1 and BRCA2, let me step back. So what we found was that in about 250 women who had breast and ovarian cancer, about 1 in 4 to 1 in 5 had a germline genetic mutation, and there were about 7 different mutations. We consider them founder mutations. And so the study we followed up on was looking at in the general population. So we found that the actual prevalence of the BRCA mutation is low, relatively speaking. But if a woman had a family history of breast or ovarian cancer, she had 1 in 35 chance of having in the population mutation of BRCA1 and BRCA2. And that about 38% of unaffected women with a known mutation in the family would have a mutation. So that's relatively high. And as a result of the initial work in the Bahamas, we went along and studied other islands in the Caribbean. And I will only talk about a few of them. So in my next slide, I have just a summary table of what is known about the Caribbean and then Black African Americans in the United States. So what we see is that about 23% of women with a mutation, with breast and ovarian cancer, have a mutation in BRCA1 and BRCA2. In Cuba, the rates are lower. We did not do that work, that's from the group. But we looked at the rates of BRCA mutations and PALB2 in Jamaica and in Trinidad and Tobago, and we find varying rates. And so initially, the idea was that maybe those mutations that were found in the Bahamas would be common in other people of African descent in the Caribbean, especially because they're small, isolated islands. But what we actually found was that in the Bahamas, they have their own unique spectrum of mutations, although recurring mutations. So 92% of the women have the same mutation. But in Jamaica, no recurrent mutations, and in Trinidad, there were only 2 recurrent mutations. And so we found 29 different mutations in Trinidad, in BRCA1, BRCA2, PALB2, and RAD51C. The story is very similar in the United States. Again, these are case studies. Actually, one paper that was just published this year is comparing unaffected versus affected women. But in the United States, we have a range of prevalence of the BRCA1 and BRCA2 mutations in breast cancer patients. So again, what does it say? It's telling us, at least in the African American population, which is not a monolith, so we have people from many different backgrounds and admixtures, that we one size doesn't fit all, and it really would benefit everyone being tested, not looking at the specific family mutations, but at least panel testing in the women who develop disease. So this is a table I took from Julie Dutil, who is in Puerto Rico. She studies BRCA1 and BRCA2 mutation carriers in the Puerto Rican population. But this is a nice summary, again, looking at whether we have common mutations, recurrent mutations, family mutations in Latin America. And again, it is rare. So important to, again, look at panels or not look focused on a particular type of mutation, but offering genetic testing to a wider array of people. So in the context of what happens when we do a study like this, at least I'm going to tell you a story about our work in Trinidad, where when we first looked at a population of 298 women diagnosed with breast and ovarian cancer, we identified who they were given their results, and then we invited them to participate in another study where we wanted to look at their family members. And so we invited them to participate. We communicated test results, we provided literature about genetic testing, what the mutations are, the risk mitigations, and these are now in people with cancer. We went over their family history, and then we had a counseling session where we invited them to invite their family members who were not affected with cancer. And so then we saw what happened. So we had 32 women who were diagnosed, who had a mutation, the probans. Then we identified 191 people in their families who were at risk. And we invited them to participate. And actually the majority of the family members participated. And then we, the majority of the probans participated. So then family members who came got tested. So those who came actually got tested. And they gave us reasons for why. So those who didn't come, they gave us reasons of why they couldn't come. Some people were traveling, but some people were also just not interested. And why we did that is because, yes, doing the study to identify women at high risk for maybe like contralateral disease or ovarian cancer, because this is in a breast cancer population, we wanted to reach the at-risk group. And so I will tell you one more thing about what we found. So this is an example of one of our family tree, family members and her pedigree. And what actually we identified is that they told us that there was minimal negative psychosocial with testing and giving them the information. But one of the impacts, I think, of the work was, and what we realized is that two things. The people who had cancer were more, did something about their disease, followed up, did more preventative surgeries, versus the at-risk family members did not follow up. And so we have had conversations with our collaborators about how we can improve screening in those at-risk family members to decrease their risk for cancer. So that's ongoing. So I'm about to end. Just wanted to say that the work that we're doing is ongoing. It's an iterative process where we're learning and also learning with our colleagues in the Caribbean. It's a partnered approach, so it's not us going in and picking things up and then leaving. And so how can we improve the state of breast cancer diagnosis and improving outcomes of women, but also improve utilization of the genetic testing in that community, and eventually how that translates to a community here in the United States. So at least in Trinidad and the Bahamas, they've set up a screening program for, well, in Bahamas for sure, a screening program, national screening program for breast cancer. And in Trinidad, there's opportunity to do germline testing outside of our study. Also in the Bahamas, we were able to help and facilitate in-clinic testing of ovarian cancer patients with our gyn-onc collaborators, and actually established a gyn-onc fellowship training program that's co-led by Matt Schomburg at UM and with the IGCS, International Gynecological Cancer Society, University of Miami, University of the West Indies, and continuing training and expansion not in a study setting, but in the context of clinical care. And so, to summarize, we found few recurrent mutations in the region, and therefore, and also work that's being done here in the United States is also finding few recurrent mutations. Also, they're country specific, at least some of them. And so it's important to do testing without focusing on particular fungal mutations. Identifying families at high risk for developing breast and ovarian cancer in our community is important, and it's still ongoing. And how we reach those families, how we reach the community to inform them and educate them about their risk, and to be aware of the testing that they need to do. And then access to testing, even more testing across the region, because a lot of it that we do is through the study, and now hoping that it is available for clinicians and family members and patients to access. And then what does it mean when we test in settings where there might not be sufficient health infrastructure to support the result if the woman does have a mutation, and what they can do about it. And then finally, one of the things that we're doing is, of course, studying the landscape of tumors that arise from this in these women. So just to say thank you, I work very closely with Dr. Judith Hurley. She's the one who first made that observation about the Bahamian women, and we've worked with Stephen Nairod and Mohammed, but what I didn't talk about is the studies where we are finishing up in the Bahamas, Cayman Islands, Dominica, and Haiti. So it's been it's a big regional effort, and with many non-governmental agencies to support this work and funding. This is one of our groups, and of course, support of my laboratory. So I'll end here.
Thanks, Sophia. Thank you. So we started the conversation talking about Ashkenazi Jews, the 1 in 40% of women with Ashkenazi Jewish ancestry who have ovarian cancer are BRCA mutation carriers. We learned that there's a lot of data about testing and population-based testing in this population and expanding it, and that there is little downside in terms of emotional aspects of it, psychosocial aspects of it. And then we learned a little bit from Sophia about the other populations that are similar in the sense that they may be homogeneous like Bahamian women, but that the rest of the Caribbean is not homogeneous. It is not a monolith, as most populations are not monoliths, and therefore maybe not focusing on founder mutations is a thought that we should consider, especially in terms of cancer prevention in the general population. So I'd like to throw it out there about the idea of using these panels. BRCA is one of the genes, but these other genes that talk about, that give us information about the risk for ovarian cancer in the general population, and that 25% of ovarian cancers are related to one of these genes. Ranjit, do you want to talk a little bit about that? Expand on what you were talking about before?
Sure. I think the model that's being developed in the Ashkenazi Jewish population is eventually can be applied, is applicable across the board, the general population. Of course, we will need to do some more research studies to look at implementation work and how you implement it and what the outcomes are in the general population. But I think you rightly point out that it could be beyond BRCA1 and BRCA2. I mean, the key principle is that the gene must have clinical utility. So not to test for something for which we can't do anything about, or we wouldn't routinely treat or do something about from a prevention or screening point of view in clinical practice. So I think we need to be careful of which genes we select. But I think there are clearly clear players with validated risks today, and some of them include, as Sophia was showing, RAD51C, RAD51D, PALB2, BRIP1, I think the Lynch syndrome genes also. And to our mind, that's a panel that could be applicable. It is something we are keen to take forward and are looking at research programs around this. So there are issues to address from the point of view of model of delivery, the outcome of it, the issue of VUS and how we manage VUS is a really important issue to address.
Not manage it. Or
yeah.
not manage it.
Or not manage it, yeah. So one school of thought is not to give the VUS result. I mean, it's population screening. So it's not meant to be 100% perfect. On another school of thought is that you can give the result and you could monitor it and see how it works. I think we all deal with uncertainty in life, and VUS uncertainty is just another uncertainty in medicine. I'm a surgeon. If I might be operating on someone, they don't have cancer, they may have cancer. They may not make it through an operation, they may die from cancer. There's huge amount of uncertainty, far greater than dealing with VUS. So I think it's one of those uncertainties which we shouldn't maybe so paternalistic about and see what patients want and what patients feel about it. So there's work to be done there. I think we've shown that we've done a fair bit of cost effectiveness modeling on panel genes and also on different health systems. And we do feel that this is cost effective and potentially cost effective. Of course, when you do implementation studies, you do more modeling to see whether it's cost effective for that health system. But I think there's huge opportunity to do precision prevention or prevent more cancers if we just change the way we think and the way we approach it. I also feel that doing these high penetrance or moderate penetrance single gene disorders is the beginning. And as we get more sophisticated modeling coming in and start doing risk adapted, after all, they're biomarkers of risk. Mm-hmm. And as we get more sophisticated risk adapted models coming in and we get validated, the keyword is validated risk estimates, you'll be able to do more complex risk stratification for populations. And you can already see that being applied in breast cancer screening in some studies. We did a pilot for ovary cancer, personalized risk protection and prevention. And I think that will be the direction of travel of the future. But what we can straight away implement and look at the implementation model and the impact is, the genes of clear clinical utility.
And so I guess the idea there would be it's an ongoing conversation. You just have to explain to the patient the context in which you're doing the testing, and then perhaps in the future genes don't change, but interpretation may change, or there may be new SNPs or something of that like that force our direction, our management differently. Can you make a comment about if you have a negative panel in a family history with somebody who's had a family history of ovarian cancer that the person has not been tested, so you don't know if they were gene positive or not, and their individual risk to the other members if they have a negative gene panel in the family. So that the initial ovarian cancer was not tested, but the family is negative, because I get that question a lot.
I think you'll have to look at the family history and individualize that. It will depend on the number of ovarian cancers in the family, whether they're 1 or 2 or 3 or more. I think there are 2 or 3 papers exploring this issue from a familial relative risk point of view. Most of them have come from the Cambridge team. Mm-hmm. And they, in situations where you have particularly high-grade serous cancer, and particularly the relative risk goes up if it's high-grade serous or if it is under the age of 50. And I think you will hit a threshold of 4 or 5% risk, which in our view is where the threshold for maybe surgical prevention should sit today. Mm-hmm. The traditional threshold of BRCA1, BRCA2, and a traditional practice used to be, say, at a 10% risk. Mm-hmm. But now with the new genes coming in and our modeling suggests that if we had a lower threshold, we would save more lives and it would be cost effective for the health system. Definitely, we've changed our practice. We would, for example, do preventive surgery for PALB2 today. or a BRIC1 gene mutation. So that means you're heading in that you could have a situation where you have a negative result and a couple of ovarian cancers in the family, or maybe even one, depending on the context, and you'll hit that level of risk potentially. So it will become more meaningful, and I think it'll become clearer as more validated data emerge from these modeling studies.
Thanks.
I would like to say that we need to be careful though, because as Ranjit himself has published and calculated, if you go for a 5% risk threshold for risk reduction oophorectomy, that means 10% of all women are going to have to undergo this procedure. And we know that there are population data, I'm talking about low risk population, where oophorectomy actually increases mortality from other causes. So, I think when you really lower the risk threshold for surgery, I think we need larger studies to address that.
So you bring up a good point, Efrat, the idea that you've got to balance your risks and benefits. So at your center in Israel, which you're studying over 1,000 women, BRCA carriers, what percentage of them end up choosing risk reduction mastectomy or risk reduction BSO?
So, I have a couple of slides. I don't know. Do we want to do slides at this point, or no? I'm fine just discussing it. Okay. So what I will say is that the rates of risk reduction mastectomy are very variable worldwide, and they range anywhere from 5% to 50%. And even in the United States, which has one of the higher rates of risk reduction mastectomy, the rate is only about 50%. So about 50% of carriers who know they're carriers actually choose not to have their breasts removed. Now, in terms of oophorectomy, it's a very different story. I would say worldwide, it's higher percentages. In Israel, it's about 80 to 90% past age 40 that have oophorectomies. And I think the reasons are clear. It's much shorter, sort of smaller surgical, more minor surgical procedure. We do give hormonal replacement therapy up to age 50 to women who have premenopausal risk reduction oophorectomy. We do have data that we published in JAMA Oncology this September, where we actually compared what happens when carriers who know they're carriers, when they're asymptomatic and decide not to have risk reduction mastectomies, how they do compared to women who only find out they're carriers after they are diagnosed with breast cancer. And the bottom line is we show that that there is increased survival. If we look at 5-year survival, the 5-year survival of women who develop breast cancer while under our care was 94% compared to 78% overall survival in women who found out they were carriers only after they were diagnosed with breast cancer. And this obviously has to do with tighter surveillance. Carriers who are followed tightly have most of their cancers diagnosed in as DCIS, not even invasive cancer, and usually there's a high rate of detection by MRI, and generally women in the general population do not have surveillance by MRI. So it's just another, I would say, argument in favor of population-based screening, but also importantly, for women who hesitate to have risk reduction mastectomy. And I will say risk reduction mastectomy is the safest way to prevent breast cancer. I think that's very clear. But I think for women who find it unacceptable for whatever reason, it's not as though we should be, saying, okay, well, there's nothing we can do for you. That's not true at all. And surveillance really can make a difference in actual survival.
So for a plug, that's the knowledge, Yodeah, knowing if you carry a BRCA mutation, even without choosing to do a risk reduction mastectomy, will save a lot lives. The 5-year survival is markedly better, I might add, compared to finding out at the time of when you develop cancer.
So knowledge is not just power, knowledge is life. Yeah, absolutely.
Exactly. And also you brought up the good point that it's important recognizing that bone and heart disease accelerated when you do your risk reduction oophorectomy. Therefore, going on estrogen, at least till menopause, till the average age of menopause, is important to mitigate that risk, because we don't want to trade one risk for another as much. Sorry?
I completely agree with that, Fred. Yes, it's critical to take HRT in premenopausal women if they've not had breast cancer, and it's safe to do so. And we also would give it till the age of 50 or 51, which is the average age of menopause. If you don't take it, the general population work says that 1 in 33 women is your numbers needed to harm for increased cardiovascular mortality. So it's really, really important to take. In our view, the balance of risks and benefits is critically important, and I concur with everything I've has said in that sense. And it needs to be informed counseling. If you tell someone that they've got a 5% chance of getting cancer, you need to tell them there's a 95% chance of not getting it. And then you will find that some of them will make a different decision.
The flip side of that.
Yeah, exactly. So how you present the information and how you counsel women needs to be an unbiased and an informed way. But if you did it at a 5% threshold, our analysis suggests you'll save 10 years of life. That's the consequence and the risk that you need to weigh up and decide. And different people will choose different things, and each person should choose what is best for themselves.
So when you're doing your counseling, what are the thoughts about full genetic counseling, where we know that if in the States, if we refer for genetic counseling, by far the minority will go see, versus pre-test genetic education, kind of focusing on what you're saying as opposed to what the outcome would be, and going down that whole rabbit hole. What are your thoughts about that?
You're asking me.
Anyway.
I think they're different models. I think they all work. If you're doing testing at cancer diagnosis, there's a mainstreaming approach where any cancer clinician or health professional who's encountering the patient has the opportunity and does it. And different people have published on this. We've worked on this, others have worked on it. It's a model that's effective, has high satisfaction, and works. On a population testing context or a general gene testing course, the randomized trial data, which shows face-to-face is equivalent to telegenetics, is equivalent to, we did DVD-based work, is equivalent to telephone counseling. I think Efrat's model of pre-test education has had high satisfaction rates. We just did a pilot where we did similar sort of web-based education information with a helpline only, with no formal 1:1 or telephone counseling process. And we showed that had high satisfaction. I think we're good to randomize that model. But yes, I think they all seem to work. And as long as people are happy and satisfied, then we look at the data, and if it's working, then that's a model that could be valid. Mm-hmm. And different providers and health systems may choose different models, but we need a model which is applicable across. We want to do it in large scale.
I think the horse is way out of the barn, right? In the United States, you have 23andMe. They're licensed to test the Ashkenazi Jewish mutation. You send them, what is it, your whatever dollars, spit sample, and you get your result back. Mm-hmm. And so I think, a little, we're sort of going around in circles because we're physicians and we're healthcare workers, and we're thinking, and I think our whole model for genetic testing has come from incurable diseases like Huntington disease, where there's nothing to do about the result, and yet the consequences are devastating. But that's not the situation here. The situation here is that, if you find out you're a carrier, that gives you power, that gives you life. So, and I like to give the analogy of fasting blood sugar. Before you have your fasting blood sugar, your physician does not discuss with you all the possible implications of diabetes, including insurance implications. They don't discuss with you the fact that there are oral hypoglycemics, and there's insulin, and there's these complications and that complications. And the reason we don't do that is because we think it's imperative that a person know if they have impaired blood glucose because there are medical consequences. So I think I think we've been using sort of models that are both relevant to incurable diseases in a different, I would say, where there are not direct medical consequences, and then we've put them on top of something that is just a general cancer screening tool. And I think that the times have also changed. People are much more aware of the meaning of genetic risk. I'm talking about the public at large. And so I think we really need to think about how to deliver this at large scale and put the emphasis where it's really important, I think, and that is in post-test counseling. And we know, Ranjit has shown that only about 10% of carriers are being identified using the current system. There was a paper last year from the Geisinger Health System where they showed that only 18% of carriers are being diagnosed just through their normal medical system. And these are all people who have insurance. They're in the Geisinger Health System. So obviously that's not the way to go. If I told you we were only diagnosing 20% or 10% of diabetics, we would all be aghast. So we should be similarly aghast at this situation.
Thank you.
Yeah, I agree with Efrat. The way to go will be digital. Yeah.
But I just wanted to add though, so I definitely agree. But one of the things that I think about often is how do we reach marginalized populations or populations that are not in the fold? In particular, the populations that I am part of. I know it's definitely something that we have to think about and innovate in a way to more engagement and not make it scary, which is because of the data that is linked to not necessarily having the mutation, but just getting the disease and the fear that is in our community.
Yeah, couldn't agree with you more. I think we need to make extra emphasis on reaching out and make sure there's equity across the board for everyone. And we'll need to develop different, context-specific models or horses for courses sort of thing. And each population needs to be addressed in an individual context.
And build the trust in different communities that that support the validity of what we're saying. Any thoughts about when you think? I mean, we chipped away at we're chipping away slowly. Ashkenazi, we know Bohemian, we know there's a Caribbean non-monolith. What about how far away are we from implementation of this? What do you think? I mean, we talk about it a lot, but
I think implementation is not easy. I think what Sophia said certainly about more marginalized populations, and even more general. I think it's very hard to. I mean, it's a combination of educating the public and of educating the medical profession, and sort of moving, a very large tanker ship, just trying to go on a different course. So I think it's going to happen. It might not happen though through the normal or regular channels, and that's why I mentioned 23andMe. I mean, I think physicians we're going to keep doing what we're doing, and we're going to do the research, get the evidence, convince our health systems, and that's going to go on at its own pace. But I think a lot of it is going to be outside pressure from for example, commercial companies, and that's why we really need to think about how do we sort of stay in control of this while actually letting it happen. And I think that's a little complicated. I just wanted to comment. I saw on one of the chats that a genetic counselor noted that most people who are referred to her come for counseling. Of course, I mean, I think genetic counselors are indispensable, but I think their expertise is much better used post-testing, after there's a test result and you look at the whole picture, as to spending more than half the time before you even have the test result. And, and are mostly discussing sort of theoretical constructs with the patients.
It's a good point. It's a very good point. And I mean, I think that using the whole team and the genetic counselors, et cetera, for post-test counseling is life-saving. It really is. It's but in the gynecological literature, the use when patients, and I see this all the time in my office, so that's why it pushed me to learn how to do the counseling. Truly, I am not a genetic counselor. It's abbreviated, but I do explain to patients the risks, benefits, and the consequences of it, and the lack of the consequences if we don't do the genetic testing, if indeed they are a carrier. It's interesting to put in so many different players. And I think, Ranjit, you and I were talking before we even started this session. In the States, one of the biggest players is the community. The community that says that, okay, if 25% of ovarian cancer is related to genes on this panel, I want to be tested for this panel. And I understand the risk of variance. I understand that we don't have all the genes. I understand that 75% of cases of ovarian cancer are not related to these genes, but as a means of mitigating my personal ovarian cancer risk, I want to know if I'm a carrier. Thoughts?
Yes, no, I agree. I mean, if you get a cancer and you pick up a gene mutation, I mean, that's potentially a preventable cancer. So it's, as Efrat also pointed out in her slide, it's an opportunity missed. I agree. I mean, it's a huge amount of opportunity missed, and we can do far more preventive. Why do we need to wait for someone to get cancer to prevent cancer? Is really the crux of the issue. And technology offers us the means to change that. Mm-hmm. So why are we not using it? And I agree that the commercial companies are going to drive it and are already driving it to some extent, but the genie's out of the bottle and it's going to come in a big way. And as clinicians, it's important to control the environment and make sure it happens in an appropriate, well-defined, scientific, safe way. Otherwise, we will be left picking up the pieces of, mm-hmm. which could end up even in chaos if we're not careful. We don't get it right. So I think that's the direction we're headed. I think the chat, there's something about salpingectomy. I could take that question if you want. So I agree that early salpingectomy and delayed oophorectomy is an option which is today available. We suggest it happens within the context of research studies. I think there isn't any good prospective data to suggest how much the ovarian cancer risk would be reduced by doing early salpingectomy in a high-risk population. But it does offer the opportunity, and from what we understand of the biology, I think a large proportion of these cancers come from the tube. So removing the tube will prevent a significant proportion of the cancers, not sure how much, one can conjecture. If one looks at the data, then if you look at the series, then 70% of the occult lesions that you find in about 1 in 20 people who have preventive surgery are in the tube and not in the ovary. There are 3 trials running, I think, one in the Netherlands, one in the States, the tube the WISP, and we are running one in the UK. So as more data emerges and this becomes more mature, this could become an option for women who would not have salpingo-oophorectomy or prefer not to have salpingo-oophorectomy in the future. But currently, I wouldn't do it outside of research study. Mm-hmm.
Yeah, I think it also depends on the motivation of why you would want to have delayed oophorectomy. So if it's for reasons of fertility, I think, there are many options and women have to be given, have to be given all these options if they can.
And in the UK, when you're doing your risk reduction surgery, your BSOs for BRCA, for example, are you doing hysterectomy at the same time, in particular in BRCA1 or no?
Great question. Okay, I will tell you my thoughts on this. I think it's a gray area. I think it's an unresolved issue. There are 3 papers recently showing an increased risk of serous endometrial cancer with BRCA1 gene mutations. Now serous endometrial cancer is about 7 to 10% of endometrial cancers. Although the relative risk or the odds ratio is quite high, the confidence intervals in those studies are very, very wide. And the number of cases are very, very small. The absolute number of cases on which the data sets are based are very small. There are studies which don't show an increased risk of serous endometrial cancer. Some of those studies which show an increased risk do not show an increased risk of endometrial cancer overall. There's a paper from the Manchester team, which is published just a few weeks ago, which does not show an increased risk with BRCA1 or BRCA2 with endometrial cancer or serous endometrial cancer risk. So I think it's an unaddressed and unresolved issue. So I don't think there's, I mean, hysterectomy is a much bigger and a much more major operation. It's got significant morbidity and risks of its, associated with it. It's got more consequences for the patient from a recovery point of view. So for the basis of serious endometrial cancer risk, we don't in our practice, and most colleagues across the country don't currently offer hysterectomy. It's not part of our protector study either. So that's our current thinking. It may change in the future as more data emerges, but there's few papers showing increased risk with poor precision of the estimate, I'd say. And there's some papers showing no increased risk. So we've not changed our practice. Other colleagues may also make the argument that you don't have to have cervix smears, or there's the issue of tamoxifen, but really we don't offer hysterectomy as an alternate to cervix screening, or all women with breast cancer and tamoxifen do we. So I don't think that idea washes. It's the issue which is unresolved is the serious endometrial cancer risk, and there's conflicting data in the literature, not strong enough in our view to change practice.
Efrat, what are you doing?
So we are the same as Ranjit. We are not doing routine hysterectomies as part of the risk reduction surgery. Obviously, if a woman has some other uterine issue, then that would push us in that direction. But in terms of just for pure risk reduction, we just do oophorectomy and self-injectomy, obviously.
Thanks. Sophia, we're getting some stuff on the chat about the Caribbean population and the ethnicity there in St. Kitts and Nevis. Any thoughts, and where the ancestry is from there?
So I wanted to add one thing about the endometrial cancer and serious endometrial cancer. So in Miami, one of my colleagues, Matt Schrombrecht, he studies particularly health disparities in the context of endometrial cancer. And it's really because in our population, which is predominantly Hispanic and Afro-Caribbean, African-American in our catchment area, we're seeing a high proportion of women with serious endometrial cancer and other high-grade endometrial cancers. And so one of the things that we've begun to do is because of course standard of care is not to offer germline genetic testing in that population. And so what we've begun to do is to prospectively collect, in the research setting, clearly collect both germline and tumor DNA so that we can hopefully have enough cases in a few years to ask the question about the presence of the germline mutation, BRCA1, BRCA2, essentially fishing where there is fish, because we know that we have a high, we have an expectation of finding the BRCA mutations in our population and then seeing if there's a loss of heterozygosity in the tumors. In particular in the Haitian and Jamaican population, where we see high rates of serious endometrial cancer. And in the context of St. Kitts is a tiny island, it's 40,000 people, and like many other Caribbean islands, except I would say for the Hispanics or Spanish-speaking islands where we have a bigger admixed population, the majority of those islands are of West African origin. So we have begun looking at ancestry, we have looked at ancestry, and we see that there are clusters of, it's not yet refined to say like where those mutations are coming from, but we have. In Trinidad, it's a big mix of Middle Eastern population, Spanish population, East Asia, and Chinese, well, Southeast Asia and East Asia, so Chinese and Indian subcontinent. And so we saw that broad spectrum of mutations, and it really correlated with the different ethnic, self-identified ethnic and race backgrounds from the people that women who participated in our study. So we think on top of the genetic contributions, of course, the islands and the lifestyles that are also increasing risk for cancer in general is moving, unfortunately, to a westernized lifestyle where we're moving less and eating more fast foods. And so that's also contributing to the increase in breast cancer diagnosis, and also the younger age of diagnosis, as we talked about before, maybe in terms of the population structure, and maybe how epigenetics plays a role in that too.
Mm-hmm. Mm-hmm. Somebody asked in the group about the difference, Efrat, maybe you can answer that, about lifetime risks and the variation in lifetime risks for breast and ovarian cancer and BRCA mutation carriers, because it varies according to the population and according to the study you're looking at.
So this is a very complicated question. And the reason it's a complicated question is because there is no single risk for a BRCA1 or BRCA2 carrier. And we know that risk is actually influenced by environmental factors. For example, the clearest example of that is what's been called the cohort effect, or the calendar birth year effect. If you look at carriers who were born in previous generations and carriers who are young women today, the risk for young women, carriers of the same mutations for women today, is higher than it was for their mothers and their grandmothers. And the reason is because all of the environmental and reproductive factors that are driving that drove at least the large increase in breast cancer risk in the general population also operate on carriers. And so, things like parity, age at menarche, et cetera, all affect carriers as well. So, I think a lot of effort has been devoted over the years to try and figure out that exact point risk estimate, but I think it's a little bit of an illusion. And the other thing is, does it really matter? I mean, are you really going to make a different decision if your risk for breast cancer is 70% or if it's 80%, if it's 60% or if it's 80%? I'm not saying, obviously there's a big difference, let's say between 20% and 70%, but we need to figure out like what range of differences really matters. So I think I saw in the comments, somebody mentioned that the Kuchenbacher article from 2017 in JAMA. I think, those are large, good risk, sort of risk estimates, but I don't think we really need to get hung up on the precise percentage. In Israel, we use data that we've actually collected in Israel, because we have, for example, higher parity, higher rates of breastfeeding than other countries, and those also affect the risks. But I think we really need the risks are high. Obviously between genes, it's important to know, I think, what the differences are, because there can be large differences in the risk. But if you look specifically at the Ashkenazi Jewish mutations, I think we sort of have general risk estimates that are fine, and further refinement is going to come from things like, polygenic risk scores, better understanding the influence of the environment and things like that.
Mm-hmm. Perfect. Any more questions?
Ranjit, I think, wants to say something.
Ranjit,
I agree with Efrat. I mean, the key thing is it high risk or not? And at the end of the day, that's a number, isn't it? And where you draw the threshold of benefit is the key thing. At what risk level you do something. And even when you put in the polygenic risk scores, even for the BRCA1 and 2 genes, while there may be some variation, you'll see some variability. By and large, those estimates will largely remain over the threshold of which you do something, but it affect your precision of that estimate. Yes.
Very good point. So the driver there is the underlying hereditary genetic cancer susceptibility gene, and affected by the polygenic risk score.
But still, even if you take the profile, which is, let's say, at the lower end of the spectrum, the lower quartile of the SNP score,
Mhm.
put the BRCA1 gene, it's still going to be over that 40% threshold for your mastectomy, which you have.
Mhm.
Think about for doing something about it.
I have to thank everyone here. I know we're running out of time and I've kept everyone ever so much longer than I promised I would. Allison, thank you. 1 in 40, Yodeah, we are so appreciative of you all talking, spending your evening, I think, with us. Evening, afternoon in the States. I am Efrat, Ranjit, Sophie, I am appreciative of your heart, your soul, and your friendship. And I so appreciate all of my texts and emails and your accessibility. And I thank you so much for spending this time. To everyone else who's listening, we can try to answer some questions. If you want to throw in an email, I'm happy to email anybody back. If you found this useful, I could talk or listen to this every day because I think that this information is so impactful. As a gynecologist with breast and ovarian risk assessment in my pocket every single day, if somebody carries a hereditary cancer gene, I want to know because there is something I can do something about and prevent. And I hope that you all have found this very helpful. It's only the beginning of the conversation. It's not the end of the conversation. And thank you. And thank you for everything.
Just wanted to add just one thing before we wrap up. Also, this recording will be posted on 1 in 40's website, and we'll be able to share it through all social media channels, including Yodeah as well, just in case folks wanted to, listen in again or weren't able to, they can check it out on demand. So thank you, but thank you all as well. Just wanted to say thank you.
Thank you. I think raising awareness is the most important thing, and you're doing a great job.
Yes.
Thank you.
Very much.
Thank you.
Thank
Keep
you.
going.
Thank you very much for
Thank you,
having me.
Sophia. Thank you.
Be well, everybody. Take care. Thank you.
Okay.
Bye-bye.
Bye.